Good afternoon. I would like to thank the organizers to invite me to talk today in this forum and also for the audiences for your patience. After lunch, I can see only few people around, and I hope that it attracts even if it is only few of you here. Um, I don't know, prostate brachytherapy, I understand from my friends that it's not very much in use in Bangladesh. And my job today is to attract you to this fascinating way of treating prostate cancer, both in different settings of prostate stagings. It can be used as a monotherapy for low and intermediate risk prostate cancer, and also as a boost for high risk patients. And of course, I use it for salvage setting when people have failed external beam radiotherapy or LDR brachytherapy. This is the timeline of brachytherapy. You can see that in 80s, the LDR brachytherapy, low-dose brachytherapy with iodine seeds and palladium seeds, has been in practice in most of the world, especially in USA and Europe. And around that time, we were thinking about when we planned something, pre-planned, the seed insertion, and after that, the post-implant, there had been some problems. And we felt also in the periphery, the use of iridium-192 would be ideal to treat. And then we started developing different things, like, as you can see, remote afterloading system. In other words, how to propel the source through the channels inside the prostate. And then you can see, once we've done that, then we did some research about what dose we should be giving, what would be the side effects, and can we actually treat patients effectively. And as you can see, in 2000s and after that, we started now practicing it in USA, Japan, and Europe, and UK. This is more or less similar thing, saying in different words, so I'll skip that. As you all know, that prostate cancer, we divide them into three groups: low-risk group, intermediate risk group, and high-risk group. I'm not going to go in detail with that one, but intermediate risk group is quite important to understand that we have favorable intermediate risk group and unfavorable intermediate risk group. And also, you'll see later on, not all high-grade, high-stage prostate cancer are the same. So they are quite heterogeneous. And this is, I love this from Grimm et al. Mr. Grimm, who was a neurologist in Guy's and who unfortunately passed away. And this is a paper in 2012. He looked at all the retrospective trials and found out that if you have a low-risk prostate cancer, whatever you do, it should be a winner. Basically, that's what it shows. 90% of recurrence-free survival in 10 years, whether you do surgery, whether you do brachytherapy, whether you do radiotherapy. It's not a problem at all. And we know later on from prospect trial, even if you don't do anything, it's absolutely fine, and you need to treat patients later on. How about intermediate risk cancer? You can see that this graph is quite heterogeneous. You can see it's all over the place. Yes, they do better, 60%, but not everything is achieving that. That's the key point from here. So let's look at the HDR monotherapy, how it evolved. So you can see it's a busy slide, and basically we looked at different combinations, different dose fractionations. How can we give it? And then next slide, we can see that these are the, after all, few years of experience, we come to the questions of, yes, we can actually deliver quite a high dose of radiation, like 116 gray, 2 gray equivalent BED, with 13.5 in 2. And if we give them one fraction, which is quite interesting for people to understand, that if the patients have got one fraction of brachytherapy, that could potentially give us 112 gray, 2 gray BED, because we feel that alpha-beta ratio of prostate is very low, 1.5. And those who are here from radiotherapy background, they would understand what I'm saying. This is the sensitivity of any cancer cells. And if it is low alpha-beta, that means if you have higher dose per fraction, you should be responding to better. Now, this is the trial that I talked about, the Jerry Morton et al. from Canada. And they looked at patients with the low risk, favorable intermediate risk, and unfavorable intermediate risk group patients. And they looked at two treatment arms. One is the two-fraction brachytherapy, and one is the single-fraction brachytherapy. And they found, and as you can see here, is 170 patients were enrolled in this trial, and one had 19 gray single fraction, the other one has 13.5 times 2. And it was obviously there are other parameters there. Prostate volume should be less than 60, and the risk group there. And they were stratified accordingly and equally on both arms. And you can see that, I'll skip that because I'm explaining it here better, that in two-fraction arm, the PSA came down very quickly. And at 5 years, it was 0.16 versus single-fraction arm, they came down to 0.65, almost like having a prostatectomy. Here, you can see that the local failure and biochemical failure, and you can see that biochemical failure for the two-fraction arm, which is the experimental arm at that time, showed 95% of these patients did not have any biochemical failure versus 73% in the monotherapy arm. And local failure, as usual, is higher in the monotherapy arm, which is 29%. But the toxicity is very, very low. You don't have to go through this busy slide. It's only 1% grade 3 toxicity, urinary and bowel. There was no toxicity from that point of view. So we know from this trial that HGM monotherapy, two-fraction, is gold standard at the moment, and with a very good control at 5 years. Most of the LDR data is there 10 years or beyond, but because we only started the journey in 80s, and now we are here, we're showing that 5-year data is pretty good in 93%, both all across low-risk, intermediate-risk group patients. This is what I presented in GU ASCO. Essentially, it showed that in our institution, when we did the single fraction brachytherapy, our 5-year data for low risk is 100%, which is comparable to the two-fraction outcome, which is 95, which is also 100%. Also, our favorable intermediate risk is 92%, and the trial arm is 93%. So we started thinking, why? Are we doing something different than the other part of the world? And we found that we've been using the neoadjuvant hormone treatment and adjuvant hormone treatment with our patients with brachytherapy, which the trial didn't. So that begs the question, with somebody who's very frail, who has got other comorbidities, where you can't really use two-fraction brachytherapy, maybe using the hormone and single-fraction brachytherapy would answer the question. Let's go to high risk. And as you can see, Grimm et al. Again, I'm coming back to his ideas. He did look at these in 2012 and found out that if you look at this busy slide, that surgery is quite at the bottom. It's 40% around there. And that blue at the top, you can see is the combination of brachytherapy, external beam radiotherapy, and hormones. And he predicted that the difference between these two is 20 to 30% if you have the external beam radiotherapy only versus external beam radiotherapy and brachytherapy. This is the first time Peter Hoskin and his group showed that, yes, if they use the external beam radiotherapy with brachytherapy and the external beam radiotherapy, they have achieved in 10 years 18% difference in biochemical recurrence-free survival. However, in this trial, their external beam radiotherapy dose was slightly suboptimal, we would say, which is 55 gray in 20 fractions, and nowadays we practice at least 60 gray in 20 fractions. This is the important trial from brachytherapy point of view that came out from Canada, ASCENT-RT, where they looked at patients who are either unfavorable intermediate risk or they're high risk localized cancer, and they randomized patients into two groups. One group had the standard 7.5 weeks of external beam radiotherapy with hormones. The other had external beam radiotherapy and brachytherapy. And the result is quite interesting because here they clearly show that 9 years, 83% did not have any biochemical recurrence in the brachytherapy arms versus 63 or 62% in the external beam radiotherapy arm. Quite an interesting finding there, which is a combination of both intermediate and high-risk group patients. And in this trial, they had about 32% of intermediate risk group and rest were high risk. And then when they looked at the intermediate risk group, look at that, it goes up. Almost 93% did not have any recurrence in 9 years versus about 70% in external beam radiotherapy only. So, but there is a little bit of an issue there because we felt that the LDR brachytherapy boost, which they used there, kind of given us a little bit more urethral stricture, about 8%, but versus where we in HDR brachytherapy is around 5% or slightly less. So, but it did not translate into survival benefit. So we felt that maybe somebody who is very young, 50, 60, even 70, as you know, in Western world, people live up to 90 nowadays, and we've been treating patients above 80 now with radical intent, radical surgery, radical radiotherapy, everything they're getting. So those group of patients may get benefit more in survival benefit as well. And this is the data that we have got, comparison between HDR boost versus LDR boost, showing equal sort of results. So in UK, we have adopted more or less HDR brachytherapy because of the toxicity boost. We use HDR brachytherapy boost. Now, if you look at these high-risk group patients, that's what Mr. Grimm et al. As group predicted that it would be 20 to 30% non-randomized data. Now we came out as 20% in our data, which was bang on right there. But there was no prostate cancer-specific mortality changes or overall survival. And there is a 10-year sort of follow-up, essentially showing the same. There is difference between the biochemical recurrence-free survival, but there is no overall survival benefit. This is interesting. This is the one that presented in ASCO a few years back, and about 1,400 patients where all these big American names you can see, they looked at their database and they analyzed retrospectively all the patients who had surgery, radiotherapy, or radiotherapy and brachytherapy combination. And this perhaps sort of explains it better if you look at patients who had, these are the patients who had Gleason 9 or 10, or T2 or T3A, in other words, slightly advanced disease. And they found that if you have radical prostatectomy, your chance of dying in 10 years is 23% with the high-risk localized patients. But if you have external beam radiotherapy only with hormones, it becomes about 24%. But if you use external beam radiotherapy and boost and HDR brachytherapy boost or LDR brachytherapy boost, they had both, and your 10-year mortality from prostate cancer-specific mortality comes down to 12%. So that's and also distant metastasis-free survival was clearly observed in the brachytherapy arm. So the duration didn't matter in a different way, and LDR versus HDR brachytherapy boost, they did both well, the same. Now, this is the trial that we did in our institution, looking at whether should we be doing brachytherapy first or brachytherapy second? Is there any difference? And we found that it was a phase 2 trial, and we looked at patients quite thoroughly with the toxicity, with their compliances and everything, and we didn't find any major differences. And what we found that the GI toxicity and GU toxicity are really, really low, even if it is a boost patient in comparison to other series. So high-risk prostate cancer, as I was telling earlier, that it is a heterogeneous group, and many patients can be cured. Brachytherapy improves, certainly, the recurrence-free survival, cancer-specific survival, and perhaps overall survival in young patients. And any dose intensification would come with a higher price purely because of the proximity of rectum to prostate. It's really, really important to understand. And these group of people will be living long period of time. So what to do about it? And we thought about around that time whether is that optimum hormone duration would be 2 years or 3 years. Should we be using surgery and then post-operative radiotherapy? And obviously we need further randomized trial. And in that talk, we thought that yes, it is heterogeneous. Yes, we can win, but obviously we need to use perhaps both radiotherapy and brachytherapy combination if we want to achieve a good local control and overall control of the cancer. Now, this is how we do it, because my job now is to make sure that I can try and get some enthusiast brachytherapists out of you. 3 minutes I have got, all right, okay. So basically, it's very simple. That's how we do it. You put a rectal probe through there. That's my urologist with me. And I'm putting the channels in. That's the channel. And you can see this held by a template. Very, very simple. And then after that, they come out of the room, and we then plan it, and eventually they're connected to the machine, and the machine then propels this source through these channels, and it takes about 15 minutes. We take the channel out. They may get a little bit of hematuria. They may stay that night in the hospital, or may go home the same night. That's how simple it is. And the reason I put the next slide here is essentially just to show that the rectal toxicity is really important when you intensify dose the radiation dose, and you can see 14%, 18%, 22%, all those things. But if we use the rectal spacer, the gel in between prostate and the rectum, you could significantly reduce it from 9% to 1% in one series, and from 41% to 16% in another series. So this is what we do nowadays. So you can see that when we put when you put the ultrasound probe, we put a gel to separate it out. And we have two types of gel. The one is the space war, the other one is Barry gel. And essentially, we put the gel inside, about 1 centimeter space we create between prostate and the rectum. Fascinating, isn't it? It's really very good for an oncologist to go in there with a heart of surgeon in, and then you put the gel in, and then you put the channel in, and therefore you protect your prostate. Lovely, and it stays only for 3 to 6 months, and it dissolves nicely after that. And this is how you plan it. You can see it's a clear. The red is your PTV there, and there's a clear distance between rectum and the PTV, and you deliver it nicely. So the toxicity from brachytherapy is mostly urethral stricture, as I talked about, and obviously the rectum and bladder is there, but not much. But these are the two things. But urethra is most. So how do we see the scope in Bangladesh? I don't know. You guys can tell me. But what I could get from my friends is this: that government-funded cancer centers are only 16. Radiotherapy service, government, available only 9 out of 16. And some of those centers may not work, the external beam radiotherapy machines. And we have to rely on private sector. Number of oncologists in Bangladesh in 300. Give me 2 minutes, please. Thank you. And then total population, obviously, you understand that one oncologist per 550,000 population, which is way, way low. You can see 1 out of WHO recommendation is 1 out of 100,000. That's the bare minimum. We have 5-fold low. And how to go about it? Because these guys will come, if they have external beam radiotherapy, every day for 20 sessions, and we can do it by 2 sessions. These guys will have radiotherapy machine, should have a lot of work to do, but you always do. You've been doing gynae brachytherapy for many years. You've got wealth of experience, and doing this is pretty simple. if you can do gynae brachytherapy in Bangladesh, you can definitely do HGR brachytherapy, HGR monotherapy, HGR boost in Bangladesh. There's no reason why you can't do it. It's the actual the mindset we have to have and say, is actually we can do. I know that we're running out of time. One more slide here, saying that obviously we need manpower, training, especially oncologist, urologist, physicist, radiographer, training, and financial support. And it's a multidisciplinary approach that we need to have to treat our prostate cancer patients here. And I think it is very exciting, and it's very, very important to understand that if we want to serve the general population, it is very cost effective, and we can serve our poor patients much more effectively without having any major complications. Many thanks.